Good evening, all. It's a pleasure and a privilege to be here on this platform, the mega platform of the National RSATI 2021. All possible by our beloved president, the most charismatic and the most enthusiastic, Dr. Bansi Sabu. Thank you so much to him and his entire team for allowing me this platform for doing this presentation. I will jump into the topic. It's a pretty relevant topic in the present times. Please allow me to share my screen. What I have done for this particular topic is I have tried to address this question that whether we should be treating asymptomatic bacteriuria in our daily practice. If we actually see let me give a background. I mean, imagine a 45-year-old female who's a diabetic with you in your clinic for many years now, and she walks into your clinic with a urine report, maybe through a health checkup showing pus cell count of 10 to 12 pus cells per ml. And then what do you do? Whether you treat it, whether you don't treat it, her sugars are fairly well controlled. She otherwise doesn't have any symptoms. So that is exactly what is the crux of my talk this evening, that asymptomatic bacteriuria in a diabetic to treat or not to treat. So firstly, what you have to understand is UTI is one of the most commonest bacterial infections among diabetic patients. ADA reports patients suffering from type 2 diabetes are more likely to have a urinary tract infection and a repeat urinary tract infection than patients do not have diabetes. Diabetic females, one, diabetic overweight people, two, and diabetic obese individuals are the highest risk of having UTI. So these three we have to be extremely careful when they come to our clinic: the diabetic female, the diabetic overweight, and the diabetic obese patient. Why is it so common in the diabetic? One, the high glucose concentration in the urine makes it easier for the microorganism to colonize. So at any point in time, they are colonized in the stream and in the entire tract of the urinary flow in the diabetic individual. High glucose concentration in urine also leads to rapid and rich bacterial multiplications. Not only colonization, they are readily available there and they can quickly multiply because of the high glucose concentration. Add to that immunological defects which a diabetic has. Which are these? Impaired glucose function, reduced T cell mediated immune response, a lower level of prostaglandin E, thromboxane B2, and a leukotriene B4. All these put together, the body cannot then launch a counter attack against this sort of readily sort of ready to attack kind of urinary tract infection at any point in time. And lastly, the bladder dysfunction because of incomplete bladder emptying caused by autonomic neuropathy adds to the problem. So because of these three major factors, UTI is very common in the diabetic. What are the UTI types in diabetes? One, asymptomatic bacteriuria. Two, acute cystitis. Three, complicated lower urinary tract infection, which includes a catheter-associated UTI. Fourth, uncomplicated pyelonephritis. And lastly, complicated pyelonephritis, which we also see as urosepsis. So very common five entities which we all encounter as clinicians in daily practice. This is an extremely important chart here. I have tried to put in the pathogenesis on a single slide. What exactly happens is, one, contamination of the periurethral area with a uropathogen from the gut. So most common being E. coli. Well, most commonly, unhygienic conditions, common public toilets. So the gut pathogen can migrate from the anal area to the periurethral area, causing colonization of the urethra and migration to the bladder. Two things can happen after that. One, colonization and invasion of the bladder, which is through pili and adhesions, as we remember in the microbiology days, and inflammatory response in the bladder and fibrinogen accumulation in the catheter in those who are catheterized, both of which lead to neutrophil infiltration, bacterial multiplication, and immune system subversion. But remember, the immune system is compromised. So the bacteria form a biofilm formation, which gives them a little protection from this sort of a subclinical or subtherapeutic immune response. Epithelial damage then is seen by bacterial toxins and proteases. Ascension to the kidneys are seen. Colonization of the kidneys happen. Host tissue damage by bacterial toxins, and lastly, bacteremia. So all of this, right from the colonization, contamination to bacteremia and urosepsis, all follows as a flow in a diabetic individual with UTI. How do we diagnose this? So examination of a midstream sample is extremely important. Sometimes we see pyuria, just pus cells are seen. Colonization is the absence of pyuria on microscopic assessment, which can suggest colonization instead of infection when there is bacteriuria. Microscopic examination allows for visualization of bacteria in the urine. And a dipstick, so presence of urinary nitrite. If it's present, bacterial contamination is seen. If it's negligible or not there, then bacterial contamination or urinary tract infection is a little unlikely in the urine. So that's how we can diagnose UTI. What are the most common pathogens? So the top four, which are highlighted, are the most common ones: E. coli, Klebsiella, Proteus, and Pseudomonas. Sometimes you also see in a rarer case scenarios Enterobacter aeruginans, Proteus mirabilis, Citrobacter furundi, Streptococcus, Staphylococcus, and Epidermidis. So these are a few common organisms seen in causation of UTI. How do we manage it now? So UTI treatment in diabetes depends upon various factors. One, are there symptoms? Two, is it a lower UTI or an upper UTI? Third, are there any presence of urologic abnormalities like autonomous bladder, automatic bladder? Fourth, severity of the systemic symptoms. And lastly, does it all occur with metabolic alterations and renal functions alterations, all of which put together the treatment modalities available to us. So I have taken two of these: acute cystitis management. So firstly, obviously, is proper glucose control. You have to get the sugars well controlled. Second is treatment tailored as per the culture results. Now remember, cultures are the cornerstone of urinary tract infection in a diabetic. You have to send out. So the case scenario I discussed right in the beginning, that a 45-year-old female who comes to your clinic with just a pus cell count of 10 to 12 pus cells per ml in a urine without any symptoms, ideally just send the cultures out on day one. Don't wait for the symptoms to develop or whatever. Just send the cultures out. The treatment is tailored as per the cultures. First line is mostly nitrofurantoin, 100 milligram TDS, or fosfomycin, or trimethoprim sulfamethoxazole combination. All can be tried. The second line then comes to quinolones and beta lactams as per the requirement of the patient. What about pyelonephritis management in type 2 diabetes? So this is now ascension of the infection up to the kidneys, wherein hospitalization should be done for intravenous antibiotic therapy. Empiric antibiotic like broad-spectrum cephalosporins, aminoglycosides, fluoroquinolones, piperacillin, tazobactam, or carbapenems are required. And severe sepsis are those known to harbor uro-resistant organisms, or patients who have received multiple antibiotic course should receive broad-spectrum coverage, which are guided by the current urinary culture report. So therefore, as I said, extremely important, whether it's an OPD patient management or a IPD patient management, to send off urinary cultures on day one of the patient being seen by you. Now the crux of my entire topic, and this one slide says it all. This is after research of many papers. Asymptomatic UTI and diabetics, do you treat it? One, a lot of studies have proven absolutely zero advantages and found in treating just asymptomatic pus cell count in a diabetic patient in the urine. Second, if you do that, it leads to unfortunate antimicrobial resistance, which we all as clinicians really are scared of. And the only case scenario where you actually are justified in treating an asymptomatic UTI in a diabetic is a case of GDM. So gestational diabetic, the lady with a asymptomatic, absolute zero symptoms, having some little of UTI in the urine, she's the only one who you should go ahead and treat. This is the only sort of case scenario where, putting across all papers and a lot of studies put together, where I found where it was justified. Otherwise, whether it's an elderly person, uncontrolled sugars, other factors, ideally speaking, no advantages are found and leads to antimicrobial resistance. So to conclude, urinary tract infections thereby are very common in the diabetic patients. We rather should be looking for them than the patient coming and telling us that, that the symptoms have started. So look for them right on the day one. Treatment of UTI without proper diagnosis may lead to antimicrobial resistance, which we should strictly try to avoid. Treatment with the antimicrobial should be based on the culture. So don't forget to send the cultures out on day one of the patient being seen by you. Only bacteriuria with symptoms of UTI should be treated with antibiotics to avoid the spread of drug-resistant pathogens, unless in a special situation, like, as I said, GDM. And lastly, a diabetic female, a diabetic overweight individual, and a diabetic patient are all the scenarios where they have the highest risk of UTI. So screen them, look for the presence of urinary infection in the urinary routine report, and ask them to follow up as per their symptoms or as per the requirement. So with that, I conclude. Thank you so much for a patient hearing. I'm open to question and answers. I will stop my screen share. And once again, I thank Dr. Bansi Sabu and his entire team for this opportunity. Thank you.